thing I do is I tell the patients that we inject a dye into their vein or into their tissue, and we use lasers to see the tracking of that dye. It helps to identify perfusion as well as, in some cases, lymph nodes and other things as well. So in a traditional sentinel lymph node biopsy, we use both technetium-99, a radiotracer, and a blue dye. In the case of laser-assisted fluoroscopy, we inject and replace our blue dye with the green ICG. This is visible using laser technology and is very easily visualized, making that sentinel lymph node clearly identifiable and, in our experience, increasing the success of the operation. The importance of using ICG as opposed to something like a methylene blue, or in some cases even replacing technetium-99, is that it can shorten your operative time. It can increase the likelihood of getting the sentinel lymph node in my practice. And it can, in my opinion, reduce the amount of injury caused by the surgery, allowing for a gentle handling of tissue. The lymph nodes are clearly visible. And we can be less aggressive with our dissection. I use fluorescence in my surgery because although the naked eye can see 80 to 90% of things going on, it can't see 100%. And the fluorescence gives me that extra visibility. It helps me identify not only perfusion of tissue, but sentinel lymph nodes, where the case may be. The sales pitch is pretty simple. Just show them. Most people see it once and they are immediately in love with it. For years we look, we see, but then along comes fluorescence and it's like pulling a curtain back. I use ICG and near-infrared imaging on all my breast reconstructions. I use it on all my sentinel lymph node biopsies.